Now I welcome Colonel Vijay Sharma, HOD Ophthalmology at FMC Pune, to present the next topic, bag fixation versus lensectomy in subluxated cataract.
So, good afternoon. Back fixation versus lensectomy. Now, as we know that zonal dehiscence can happen in trauma, it can happen during complicated cataract surgery, it can happen in ectopial lentis, as in Marfan syndrome and other syndromes, and also pseudoexfoliation syndrome. So, how do you manage such cases of zonal dehiscence? You have got so many options. When you do a nucleotomy techniques, at that time you should use a capsular hooks rather than iris hooks, and you can hold on to the side where there is a zonal dehiscence. Then in cases there is up to 90 degree or 3 clock hour of dehiscence, you can use a normal CTR. Otherwise, if dehiscence is more than that, you can use a single eyelet or a double eyelet CONE ring. Also, you have got capsular segments which you can use nowadays. So all these options are available. Now, I'll just show a few, just two videos related to this. Now, if you see this, this is a post-traumatic cataract. There is a capsular, posterior capsular break was there, and that had healed. Now, you have to go very slowly in such case, because you may have dehiscence in such cases whenever you're doing the surgery, or onion peel rhexis was done, first a small and then larger. And once you have completed the rhexis, as you can see, you just emulsify the nucleus, and once you have completed so you just see it here now. So it is very important to note. Now just note inferiorly at 4 and 5 o'clock, you can see that there is a dehiscence. Dehiscence is around 3 clock hours. So in such situation, how do you manage intraoperatively? So now you just inject viscoelastics so that all the bag that goes into the place. And once you have injected viscoelastic, then you take the CTR. You inject the CTR. Again, if you have a preloaded CTR, that is much better to inject in a unloaded CTR. Now, I normally use a 2-dialer technique. Many people prefer to use a forceps rather than a 2-dialer technique. So, in the 2-dialer technique, remember that when you take it in, you have to take it inside the capsular edge. Don't leave it just in the anterior chamber, because otherwise it will be anterior to that. And once we have put the CTR in place, when your dehiscence is taken care of, then you can put an IOL. Now, the posterior capsular tear, which is healed now, that had maintained luckily during the entire surgery. It didn't open up, otherwise we could have we might have had to implant maybe a multi-piece in the sulcus. So this is one. And the second case is about this is about Marfan syndrome with the zonular dehiscence, significant zonular dehiscence, which is around 8 clock hours. So how do you manage such cases? Such cases, our preferred technique is doing a intralenticular aspiration followed by glued IOL. This was a 10-year-old child with a Marfan syndrome. So in this, I'll just go step by step. You just make the first you make the flaps. So in the flaps, what our preferred technique is, while you are making the flap, you make the flap much ahead. You make a pocket also along with the flap. So you can see the yellow is the flap, and there is a pocket, blue color. So in the blue color flap, what you can do is, when you have to implant the glued IOL, you can put your haptics into that pocket. Otherwise, you can use a Yamane techniques or any of the newer available techniques. Then you make a stab incision into the lens. Once you make the stab incision, then through these two stab incision, you take your bimanual irrigation and aspiration port inside the lens, and just do a irrigation aspiration inside the lens. Now what you will achieve is entire cortical matter, which is very soft. You can aspirate that completely by this, and nothing will go down into the vitreous cavity. So once you have achieved it, as you are seeing this, do a good irrigation aspiration, remove entire cortex from there. And also you can take help of your irrigation cannula to put the nucleus centrally, because 8 clock hour subluxation is a big amount of subluxation. It keeps going outside. Now once that is completed, you are left only with the capsular bag. And now just eat away the capsular bag using a cutter. It comes out very easily. Now you have got a very clean removal of the subluxated lens, and this is the time when you make a 3.2 millimeter incision, and after you have made the 3.2 millimeter incision, then you can insert your multi-piece IOL. The technique is same. I'll not discuss it in detail, but the leading haptic, you hold it with the glued IOL forceps from the side, and similarly from the other side, once you are exercising, you can exercising the trailing haptic as well. Once this is out, that is the time you can put a single suture at the main incision site, and you just tuck in those haptics into the pockets that you have created. So your bleed IOL is never under tension in this, and if you use a 26 gauge needle, there may be some amount of tilt in the IOL, but usually you do not get any tilt in this, and then you just put a glue and for the flap, scleral flap followed by the conjunctival flap, and you just close it. So to summarize, if you have got a less than 90-degree subluxation, in that case, less than 90-degree zonular dehiscence, in that case you can use a CTR or a capsular segments. More than 90-degree, you can use a CONE, singular or double eyelid CONE, and a capsular segments for ectopia lentis, because it's a progressive zonular weakening, because the pathology is there. So in such cases where there is a progressive pathology or zonular weakening, in those cases you can go ahead with the intralenticular aspiration and put a glued IOL in such cases. Thank you very much.
Just one comment. Like as Vijay just suggested, in extreme scenarios, it is better to take out the lens and put in a glued IOL. That is one. And second thing is, if you are starting, so it's easier to again do a lensectomy and do a glued IOL rather than going and trying to fix the back. It's very difficult to fix a back. So until you're very conversant with fixing a back with a CONE, it is much easier to do a lensectomy and doing a glued IOL. So if somebody has to put in some effort in learning a surgery, probably the first thing you should learn is a glued IOL. That saves your day any day. CONE is definitely, again, fixation it becomes difficult.
Thank you.